When you think about shock, you might think about something like this. Macaulay Culkin with his shock. Sometimes people in the lay world, consider shock to be that situation when you don't feel pain after you are maybe in some type of traumatic event. And shock actually means something more related to cellular work and perfusion, but you can also sometimes hear this concept of how people tolerate those traumatic situations as well. So let's get into what is shock. Shock is not really a disease in and of itself. It is a syndrome. A syndrome tends to have some characteristics that define it as it goes through a certain type of process. So it's just like this predictable kind of pattern. I am going to talk to you about a couple definitions of shock, and one of them is that shock is a life-threatening condition of circulatory failure, causing inadequate oxygen delivery to meet cellular metabolic demands and oxygen consumption requirements, producing cellular and tissue hypoxia. Okay, so you don't need to memorize that definition by any means, but you can hear some themes in it, and that it is a life-threatening situation. And there is circulatory failure. There's issues with oxygenation, with cellular metabolism, and meeting the oxygen needs of the body, and hypoxia. So you see or hear the main concepts of perfusion and gas exchange that are huge parts of shock. So some also describe it as a syndrome in which there's decreased tissue perfusion and impaired cellular metabolism. What does all of this mean? All of the shocks have one thing in common, and that is low blood pressure. All of them have low blood pressure. That can be treated and managed a little bit. Sometimes requires quite a bit of work to do that. It tends to have kind of a process that goes through with some variations based on the type of shock. But we tend to see that issue with perfusion caused by an insult of some sort, which we will discuss. Okay, so there are multiple types of shock, and they're all very interesting. And you can have overlap of shock. So you can have a patient that has a few different types of shock all at the same time. So maybe we'll talk about some examples of when that might happen. So we will talk about cardiogenic shock, which is like a shock that's a very, very severe type of heart failure, if you can consider it that. We'll talk about hypovolemic shock, which is like a very, very severe form of dehydration. And then there's a category called distributive shocks, and these are neurogenic, anaphylactic, and septic. And then our last type of shock is called obstructive shock, and that can be caused by several different situations. So let's talk about these. We're going to first talk about the stages of shock, and then in our next video, we'll talk about some of the types of shock. Okay, so there are some stages of shock, and it's important to kind of know a little bit about what your patient might look like so that you can intervene early for your patient. It's good to know what is bringing them in, what kind of is their history, what happened beforehand. All of that stuff can really help you to identify the etiology of the shock so that you are going to be prepared for the potential of shock. So let's talk through a little bit of these. And you might see some slight differences on a couple of these things based on the book you look in, but we'll try to cover the main highlights. So the first stage you can see over on the side is your initial stage. And in this stage, you might actually not really notice this shock occurring. So your body is kind of, I'm not going to use the word compensate because there's a compensatory stage, but it's just pretty early that you might not see a whole lot of symptoms yet, thus it is very hard to see. You might see very minor changes in blood pressure, very pretty much undetectable changes in blood pressure and some increase in heart rate. Your book didn't mention, but others have mentioned the potential of some changes in respiratory rate or mental status. What's happening in this stage are some metabolic changes and lactic acid production. So you may not really see a whole lot of that actually manifesting with physical assessment findings. So the compensatory stage is really where you might start to notice some of these things and be able to intervene for your patient and let the provider know about this concern. So in this stage, you would see an increasing heart rate. The one exception to that would be neurogenic shock. We'll talk about how in neurogenic shock, there is a decreasing heart rate. Okay, so you might see some increasing heart rate, increasing respiratory rate, decreasing blood pressure, with the exception of septic shock. Sometimes septic shock, actually the blood pressure looks really pretty good for some time. And your body is kind of compensating. They actually really look okay. And so that's why it can be kind of difficult to figure out. Then the blood is shunting kind of to the vital organs. So there's going to be a little bit less perfusion of some organs. And there's some decreasing urine output, but there's not yet kidney failure. And this is what happens in this stage is there's sympathetic nervous system activation. So that is what's increasing that heart rate and not sending as much to the kidneys as you could imagine. So there's a little bit less going to the kidneys. So these are some subtle changes that the nurse would really need to pay attention to if you're watching your patient and concerned about this potential. So really wanting to intervene early for this patient for the best outcomes. So the next stage is the progressive stage of shock, and you see a more significant drop in blood pressure. Mental status changes. And now you really have to think about this and ask the family about this. These may not be that the patient's really unconscious. They're just different than their normal. So I have a story. There is a lady named Laura Gasparis von Frollo. And when I was getting my critical care nurse certification, she did these great CDs that would help you to study. And she tells the story of a patient that she was supposed to monitor in the ICU because they found partway through his prostate surgery that the instruments were not clean. So they were doing surgery with dirty instruments. So she was just supposed to watch for sepsis and septic shock. So she has him back in the unit and she's watching him and he's acting all goofy and fun and lighthearted. And his heart rate's a little bit elevated. And then she's like, maybe I better count his respiration. So she does, and they're like about 30. And then she asked his wife if he's normally like that. And he's normally something like an accountant and very serious, but he was kind of being silly. And she said, no, he's never like this. So mental status changes are just different than the patient's normal or something to note, whether they're being silly or laughing or having other types of things. So pay attention to those mental status changes that are just different than the patient's normal. You might see things like skin changes, like they're cool and clammy, pale, that kind of stuff. An increasing respiratory rate, even more, increasing work of breathing, and potentially some more risk of organ failure. So at this point, the body's really not able to compensate anymore, and the body systems are affected, which is why you're seeing these issues. There might be some altered lab values, some edema, perhaps, depending on what's going on. So this is really when very aggressive treatment is needed for this patient if you haven't caught it prior, but the earlier you catch it, the better. The patient might also have disseminated intravascular coagulopathy, so they can have issues with bleeding and clotting all at the same time. And also risk for acidosis. And so you're going to watch that ABG for acidosis, which is quite likely. In the irreversible stage, the mortality rate's about 50%, and the rate of death increases about 10% or so for each additional organ that fails. So that this is really when we're no turning back, not a good stage here. So you're going to have very significantly decreased or absent pulses. The patient might not be responsive. They might be cold or dusky or cyanotic or kind of have that modeling. So these are really very severe, very decreased oxygen sat, and like I said, multiple organ failure. The table 34.2 in your book has some good ways to kind of look at this that might help you as you're understanding these different stages of shock. But I would really like for you to pay attention to things such as an increasing heart rate, increasing respiratory rate, altered mental status, those little things that you're noticing even before the blood pressure significantly changes that would give you indication that something is wrong. Okay, we're going to stop there for this video and then start up next with cardiogenic shock.